Hi, good afternoon. I'm going to speak with you this morning about the evaluation of Modifier 63. Payments are usually dependent on RVUs. A fixed number of RVUs make up a given CPT code. RVUs are supposed to reflect the total work it takes for a provider to care for a patient, which includes the intensity and complexity of that interaction. But measurements of intensity and complexity are difficult to find. Previous studies have shown that things like length of stay, complication rate, mortality can all be associated with RVUs. Additionally, physicians can request modifiers to adjust payments for specific procedures under certain circumstances. Modifier 63 allows physicians, normally surgeons, to request additional payment when taking care of an infant that's less than 4 kilograms. So as pediatric surgeons, you know that taking care of these very small infants is complex. The difficulty with starting an IV, the hemodynamics during the operation, and even the details of that operation all contribute. We were interested in looking at this modifier from an objective perspective and asking, was there objective data to support the increased work of operating on a child that's less than 4 kilograms? To study this, we looked at the pediatric NSQIP database for 2018. You can see our inclusion criteria here on the right. We looked specifically at children who were less than 4 kilograms and those that were between 4 and 10 kilograms. In order to look at the procedure, it had to be performed at least 10 times in each of these groups. We were interested in 3 outcome measures. The first was procedure time. This was skin to skin, how long it took the surgeon to do the procedure. The second was anesthesia time. This is important if you consider the difficulties of starting an IV or waking the baby up from anesthesia. The third was length of stay. This helps tell you a little bit about how sick the child was, how long they stayed in the hospital. These were the 11 unique CPT codes that we studied. You can see things on here like tracheoesophageal fistula repairs, enterectomy with anastomosis or ostomies, and VP shunt placement, to name a few. So from the database, there were 119,000 observations, a little bit more than that. We narrowed this down to 1,546. Of that, there were 343 children who weighed less than 4 kilograms. These would be your Modifier 63 eligible children, the ones you could bill for. There were 1,204 children who weighed between 4 and 10 kilograms. This is a heat map of our results. It's a little bit busy, so let me take a second to walk you through it. On the left, you can see those 11 CPT codes that we included. At the top are the 3 objective measures: operative time, anesthesia time, and length of stay. Let's look just at the first row of tracheoesophageal fistula repairs. You'll notice that some of the boxes are shaded in red. This indicates that it took a longer time for larger children, those in the 4 to 10 kilogram group. So if you look at operative time, you can see those larger children took about 191 minutes for their operation, versus those that were smaller, less than 4 kilograms, took about 150 minutes. This was also true if you looked at anesthesia time. Larger children took 277 minutes, which was larger and longer than the smaller children. You'll see that length of stay is shaded in yellow. This indicates there was no difference between the 2 groups. So now if we look back at the entire chart, you get a sense that there's one other color on here, and that's green, but it only shows up twice. This is when you see the children who are less than 4 kilograms took longer. So that only happened with anesthesia time for open gastrostomy placement and length of stay for VP shunt placement. Otherwise, you can see the majority of outcomes all had larger children taking longer. This is true for most of operative times that we noted and the anesthesia times. So based on these results, we found no evidence to support a child less than 4 kilograms requiring increased time for their operative time or their length of stay. If anything, we saw that larger children were taking longer. Pediatric surgeons know that there's increased complexity and intensity associated with caring for these children, but basing this on a child's weight doesn't necessarily accurately take that complexity into account. Instead, we need to figure out a more nuanced system of objective measures to communicate that complexity. Thank you.
Dave Notrick at Phoenix. So, it's interesting because you're comparing the pediatric patients less than 4 kilos to the pediatric patients that are more than 4 kilos. But I think that a lot of the motivation for developing the modifier was to compare these to adult patients. And so, I'm not saying that there's no role for it in pediatric surgery, but really it's a comparison to the adult world. And then the other small comment I'll make is a lot of those codes actually are not eligible for the modifier, so TEF and gastroschisis.
Mm-hmm. So just to address your first point, when you have adults, like you said, it makes sense that longer operations require increased complexity and intensity. But a lot of times in children, you're working expeditiously to try to get the child off the operating table. That's why trying to design future RVUs and CPT codes that take things like that into account, other objective measures, whether it's a combination of complications, length of stay, preoperative characteristics, even something in your operative note, that could all take it into account.
Thank you for a great talk. Steve Hsu from Stanford. Just another comment to expand upon David's comment. One of the things that I don't know if it's appreciated is that there are various codes that are in the AMA book, but it doesn't really matter if insurance doesn't pay for it. So Modifier 63 is a common thing that a lot of insurers in California actually don't recognize, even though it's sitting there. Mm-hmm. So one thing to consider as far as resources to change things. The other thing is that exactly what David said, they were really more modified towards differences in pediatric care versus otherwise, and that the pediatrics are neonatal specific codes like gastroschisis, TF, 44126, 44127, which is the atresia codes, those aren't eligible for 63. However, you can always consider using, for those patients that have longer operative procedures, Modifier 22. Mm. And that's much more readily acceptable, although it takes a little bit longer. I don't know if you guys looked into those codes instead as opposed to the 63s. Thanks.
We haven't. It's a good thing to bring up. One of the things about Modifier 63 that we recognize is even if it might not be necessarily applicable to some of these because it's already baked into that RVU, it still is relevant to consider time as an objective measure and to see in those populations how time affects those kids. So is it still relevant? I think so. So that's why we chose to continue studying it.
We have one more question.
Justin Lee from Phoenix. Great study and also showing utility of NSQIP data to answer clinical question. So when NSQIP captures time from ED to OR, time to procedure as they started doing last few years, they're actually rounding it by 15-minute blocks. Mm. So I'm just wondering, when you look at anesthesia time or operative time, is that raw minutes per case captured, or is that rounded up or down?
I'm not sure. I would have to look back, so I honestly
so I wonder if that would actually impact your difference in minutes.
Mm-hmm. It's a very good question.
Thank you.
Thank you.
Thank you.